next speaker is Rudvij Pandya.
Good afternoon, everyone. I'll be presenting on an atypical case of toxoplasmosis. I have no financial disclosures. So this is a case of a 24-year-old female who presented to us with a chief complaint of diminution of vision in the right eye since the last 10 days. She did have less vision in the very same eye before. The presenting visual acuity was counting fingers 1 meter, and she had an anterior segment reaction also in the form of small sized keratic precipitates with the cells of +2. The vitritis was of grade 2 in the right eye. The left eye was normal throughout the course of the follow-up, so I'll be describing the right eye in the subsequent slides. So here we can see that there is presence of vitritis, and if we closely observe the fundus photograph, we can note that there is an incomplete posterior vitreous detachment that is noted, and there is presence of posterior hyaloid precipitates. Another glaring features that we note over here is around close to 5 to 6 disc diameters of yellowish necrotizing retinitis lesions, which is ill-defined in border along the supratemporal arcade. Now, if we see very closely also, there is similar sized lesion in ferrotemporal arcade, but here the color of the lesion is yellow, and on clinical examination it was more like a gliotic scar. If we see very closely to the just next to the scars, there is presence of hyperpigmented scars along this. Now, I'll directly jump to the diagnosis. We made a diagnosis of panuveitis with necrotizing retinitis, and the etiology was toxoplasmosis. Now, in the subsequent slides, I'd like to explain why we made a diagnosis of toxoplasmosis in our case. So first of all, let me take you to all the investigations or the clinical signs. So now why there is a partial PVD that is seen in our case. So generally what happens in cases of retinitis is the retinal surface is very sticky. So PVD generally when it occurs in rest of the hairs, and it is attached on the surface of the retina. Now, another important clue what we get from a posterior hyaloidal precipitates is that it indicates an active infective foci. Now, they can also be used as a marker of resolution of our images, so they are the first one to go off if the inflammation starts to heal. Now, they are not specific for toxoplasmosis. They can be seen in any active infections. They have been reported in CMV, syphilis, and also post-febrile illness. Now, what actually clinched the diagnosis over here is presence of different colors of lesions and the hyperpigmented scar. Now, what would a fibrotic scar indicate? That this active lesion may also heal with quite amount of fibroglial tissue. And a classical teaching of an hyperpigmented scar and adjacent and active retinitis, we err towards sides of toxoplasmosis. Now, but in our case, the lesion size is very large. For a typical toxoplasmosis, it needs to have 1.5 to 2 disc diameters of a necrotizing retinitis over the posterior pole. Now, what does a large size or multifocal size or the retinitis which spreads horizontally indicate? It indicates an immunocompromised host. So, our 24-year-old female had a history of HIV, and she was treated appropriately with an intravitreal Kindadexa injections and Bactrim also, and she was started Bedford for her anterior uveitis. Now, over the course of time, when the vitritis is removed, that we can see over here, there is presence of an subretinal hemorrhage that is noted, which gave us indication of an CNVM. We have already reported this in our previous thing, that if you in such cases, if you have a hemorrhage, look for CNVM. The patient was appropriately treated for the very same, and over the course of time, the patient received 3 Clindadexa injections, 2 bevacizumab, was continued on heart therapy, and was on Bactrim DS medications. Just one last slide, and probably I would like to ask a question to Dr. JB sir also over here. How do we continue Bactrim DS? How long do we continue Bactrim DS in a patient of an immunocompromised host? We generally I've read it through it that it is not only an ocular prophylaxis but also a systemic prophylaxis for a pneumocystis jirovecii pneumonia prophylaxis, and generally greater than 200 cells is CD4 count till which we would like to do that. So these are my learning points. Hyaloidal precipitates will suggest an active infective foci. The gliotic star would indicate that the active lesion might go ahead and heal up with an active gliotic scar. Large size of lesion, horizontal spread, multifocal spread will give us towards an immunocompromised state, and we do continue bacterium prophylaxis, just not for the ocular purpose, but systemically also. Thank you.
So immunocompetent patients, we give 8 weeks treatment of Bactrim DS and clindamycin, and in some cases macular lesions or recalcitrant lesion, we give intravitreal clindamycin with dexamethasone. But immunocompromised patient, we need to look at the clinical resolution, and the treatment can be continued for 6 months or even for a year. The long-term treatment with the Bactrim prophylaxis, or 1 tablet twice a week can be given.
Thank you.
Rudvij, I am having one question. Whether this patient was diagnosed for that HIV previously or later on?
Actually, she was never diagnosed. So what happened was then when we saw these lesions and hyperpigmented scars, we came up with a diagnosis of toxoplasmosis. But being atypical, we poked into the history. So the patient was accompanied by her uncle. So we asked the patient to be, we spoke with the uncle. So on poking the history, her parents had died because of HIV. So we are suspecting a vertical transmission which never came out
because this was the atypical presentation of toxoplasmosis. In atypical toxoplasmosis, we have multifocal lesions, particularly in the patients of HIV or any immunosuppression. That can be because of the various drugs.
Yes, all the other investigations were done. The patient was, I do agree that cotrimoxazole may still behave or act against syphilis also, but it was TPHA and VDRL both were done.
But why that vitritis element was there? Because if immunosuppression will be there, so vitritis in HIV patients, we don't see, even in the typical toxoplasma lesions, we don't see vitritis.
CD4 counts at presentation was somewhere close to 200 or anything. That was actually our very... So the CD4 count at presentation also was somewhere close to, if I am not wrong, 180 or something. So she was still not that amount of immunocompromised for the vitritis to be not there, but I do agree it was very rare. If we say that it's an immunocompromised host and toxoplasmosis, to have vitritis is rare.
Yeah, because if it was a immunocompetent patient, vitritis is there, but in immunosuppressive patients, vitritis element is not there. They can be multifocal. They are usually seen bilaterally. Yeah. Those are atypical presentation, but the vitritis was hitting. Maybe there will be something else. Maybe the dual pathology. As JB sir was ruling out to that syphilis.
Yeah.
Okay, thank you.